Hello, everyone, and welcome to this year's first webinar of the International Eosinophil Society. Today we have a very timely and interesting topic. Next slide, please. That will be covered by two distinguished speakers who are really masters in the field. The question that we're going to try to address today, this pro-con debate, is eosinophils are the key inflammatory driver in severe asthma. And we have selected two great orators who are, as I said, both masters on the topic, but also masters of debate. And perhaps one or the other is going to be able to convince us whether eosinophils are or are not the key inflammatory drivers here. Next slide, please. So just as a brief reminder, this is the mission statement of our society, and the webinars that we present and that we have been presenting for the past 2 years are really an important part of this mission, because we really want to inform and educate about eosinophils and about eosinophilic disorders. Next slide. And here are a few housekeeping rules and information. So during and throughout the presentations, you'll have the opportunity of asking your questions. Unfortunately, not verbally, but you can enter them in the question and answer button. And at the end of each session, the moderator will address these questions on your behalf to the speakers. If you have any technical difficulties, as usual, the easiest solution is to try to log off and then log back on. And this is a special webinar because we will be polling you both before and after the presentations to see just how convincing our orators have been and how much you have learned during this webinar. The webinar is being recorded and it will be posted pretty rapidly afterwards on our website. And we also have the opportunity of having live transcription. There's a little button at the bottom of your screens with the show captions, which you can press on to see these captions. Next slide. So it's my pleasure to introduce our moderator, Praveen Akuthota, who's a professor of clinical medicine at the University of California, San Diego, working both as a pulmonologist, but also in the ICU department. And he will be introducing our two speakers today and moderating the polls.
Thanks, Florence. I am the moderator, but I'm not sure if there's going to be anything moderate about either of our speakers' presentations. As Florence mentioned, we have two very fantastic speakers today. We have Professor Ian Pavord from the University of Oxford. He's also an honorary consultant physician at Oxford University Hospitals. He'll be taking the pro position for eosinophils being the key inflammatory driver of severe asthma. And then the con position will be taken by Professor Michael Wechsler from National Jewish Health in Denver, Colorado. He leads the National Jewish Cohen Family Asthma Institute, and he's a professor of medicine there as well. We will start before Dr. Pavord's pro presentation with a couple of audience polling questions just to whet your appetite to start thinking about the topic. And Andrea, let's start with the first polling question, which is really just our top line of this debate. And you'll see there, are eosinophils the key inflammatory driver in severe asthma, yes or no? Just go ahead and answer. Yes, I have to answer too. I won't tell anybody what I answered. Okay, Andrew, are you able to show the numbers?
I think we can get the reporting afterwards.
Okay, great. We'll see before and afterwards. And then also to whet your appetite, question number 2. Oh, we can see them. Okay. Looks like Dr. Wechsler is going to have his work cut out for him based on these numbers. And then let's go with the second polling question, which you should have pop up in your Zoom in a second. What percentage of patients with asthma are believed to be super responders to eosinophil depleting therapies? And you can see the choices there between 10 and 100%. And I guess I should also answer again. Okay, if you close that one, Andrea, I think we'll see that one. Okay, so we got a nice spread here, no 100%. So I think this question gets a little bit at being a little more granular, pun intended, about how important eosinophils are and as inflammatory drivers in severe asthma. With that, without further ado, I'm going to pass it over to Professor Pavord for the pro position. Thanks, Ian.
Thank you very much, Praveen, for that kind introduction, and also Florence. I'm still reeling a little bit from being called a masturbator, which could be misunderstood. But anyway, I don't know what you feel about that, Mike.
Sure you are.
So this is my topic. Eosinophils are the key inflammatory driver in severe asthma. I was very interested to see the polling question. I think the debate is won already. I have some relevant conflicts of interest that are set out on this slide. So what I'm going to do today is start by some key information about my opponent that you really do need to know before diving into the topic and arguing that eosinophilic airway inflammation is a key mechanism in severe asthma, how it contributes to morbidity and how you can identify it using simple biomarkers. And the essence of my debate is that the eosinophil is the key component of this inflammatory process. And there will be two strands to my argument. Firstly, the similarity of the clinical effects of monoclonal antibodies blocking IL-5 and those that block type 2 inflammation more broadly, notably anti-IL-5 receptor alpha and anti-TSLP. And my opponent will need to convince you that there are clinical benefits of those more broad inhibitors. I'm also going to look at the response to prednisolone in patients treated with anti-IL-5, or more accurately, the lack of response to prednisolone as evidence that depleting eosinophils has achieved very complete blockade of this process. And when we get a chance to respond, I think hopefully Mike and I will be able to reach a consensus. And I think there is an emerging consensus that we're very lucky as clinicians to have these different biologics, and that it should be possible for us to find the right biologic for the right patient. And there's some new and interesting thinking on that topic that we will discuss. So my opponent, he's a nice guy. He's a Canadian, and as a lot of Canadians, a lovely guy. He's a very gifted speaker. In another life, I think he would have made an excellent second-hand car salesman. And he might be tempted to resort to underhand methods. I have, for example, seen him recording my talks and comments that I've made at advisory boards, which I think is very underhand. And I'm very aware of the mantra in pro-con debates that if you can't win the debate, go for the opponent. So prepare yourself for this. And it's important to see beyond that, to see beyond the showmanship, and ask, as a presidential candidate memorably did, where's the beef? Do these arguments hold up to close scrutiny? So this is the process we're talking about, eosinophilic airway inflammation, which is a process where these potentially very toxic cells, eosinophils, are moved from where they're produced in the bone marrow to the airway epithelium, where they cause a lot of problems. And this is under the control of the three key cytokines, IL-4, IL-5, and IL-13. And there are various different elements to this process, including in younger patients, particularly a tendency to form IgE antibodies to harmless aeroallergens, and a rather more peripheral link with an abnormality of airway function that you could characterize as airway hyperresponsiveness. Now, I think most of the problems associated with eosinophilic airway inflammation can be explained by the presence of activated eosinophils in the airway epithelium and airway lumen, where they change the physicochemical properties of mucins resulting in the formation of hard, sticky mucus plugs, which are particularly likely to impede airflow and cause non-bronchodilator responsive airflow limitation. And the effects on promotion of allergy and airway hyperresponsiveness are very much secondary to this dominant process, certainly in severe asthma. Now, an important feature of this process, and this has been a game changer over the last 10 to 20 years, is it's very recognizable using simple biomarkers. Blood eosinophils and exhaled nitric oxide, or FeNO, are the two most useful biomarkers, and they probably tell you about different aspects of the process. So eosinophils identify the systemic reservoir of eosinophils that could move to the airway epithelium in the right circumstances. And FeNO tells you about the strength of the chemotactic pull that's pulling eosinophils towards the epithelium, if you like, the magnet. These biomarkers in combination tell you about risk, beautifully demonstrated, I think, by Simon Couillard's asthma attack risk score, which is shown here, indicating that exhaled nitric oxide and blood eosinophils are collectively the most important risk factor for asthma attacks across the range of severity of asthma, increasing the risk of an asthma attack by about 4-fold if both FeNO and blood eosinophils are present. But it's not only asthma attacks that eosinophilic airway inflammation drives, it drives airway remodeling, a process where the airways become irreparably narrowed, leading to disability, particularly in later life. And also what I like to call people remodeling, which is a process where the inflammation or the treatment that is required for that inflammation affects the person. And the side effects of oral corticosteroids, which are shown on the far right of this slide, are particularly important components of people remodeling. So I think it's very clear that eosinophilic airway inflammation is a process that's associated with risk and an uncertain future. And it has become clear that it is the dominant inflammatory process in severe asthma. I think Mike will not disagree with this. So some evidence for that statement is in the QUEST study, which is a big phase 3 study of moderate to severe asthma, where patients were not selected on the basis of type 2 biomarkers, showed that only 20% of the participants had true type 2 low disease, so a FeNO below 25 and blood eosinophils below 150. And in the RASP UK study, where we particularly focused on patients with biomarker low severe asthma, and we adopted a biomarker-directed management strategy, which involved down titration of corticosteroids, only 5% of the participants of this study developed had no evidence of type 2 airway inflammation after corticosteroid weaning. So this is a process that's present in most people with severe asthma and is a dominant process in many. Now, that's the basis for the biologic treatments that have had such an enormous impact in the clinic. And this cartoon shows the different treatments we have that modify eosinophilic airway inflammation, acting at different points in this cascade. So you have the anti-IL-5 biologics, which are particularly depleting the circulating pool of eosinophils, whereas you have dupilumab targeting the IL-4 receptor alpha and tezepilumab targeting TSLP, which are working much more at the magnet end, if you like. And then you have omalizumab, which is modifying this allergic loop that's associated with type 2 inflammation in younger patients. If we look at the anti-IL-5 biologics, they deplete blood eosinophils. They don't affect the magnet, so FeNO and IgE are not affected. So they have no effect on these other processes that Mike will probably argue are important drivers of disability and the problems our patient has. Their effects are predominantly on exacerbations, and the effect is very blood eosinophil dependent, as you would expect. And really, essentially, the relationship between blood eosinophils and the benefit of treatment is identical for mepolizumab, which targets IL-5 directly, and benralizumab, which inhibits IL-5 signaling by targeting the IL-5 receptor alpha. The higher the eosinophil count, the higher risk you have of having an asthma attack if you're not on anti-IL-5 treatment, and the bigger the benefits of treatment. If we look now at dupilumab, which, as I've said, works more on the magnet side of the inflammatory process, the benefits, as you would expect, are very strongly associated with exhaled nitric oxide, and it's a very similar picture. With increasing exhaled nitric oxide, you see an increasing risk of exacerbation and increasing benefits of treatment with dupilumab. And this applies for exacerbations on the left, lung function in the middle, and the lung function at week 52 on the right. Now, this is an interesting post hoc analysis. One feature of the QUEST phase 3 dupilumab study is it involved just under 2,000 patients. And there was a huge statistical power to do subgroup analyses. And this looks at determinants of response to dupilumab. And I want you to look particularly at the allergic versus non-allergic. And this is not a relevant variable when it comes to the efficacy of treatment. So the benefits of dupilumab cannot be due to inhibition of this somewhat peripheral mechanism. I'd also like you to look at reversibility, with the caveat that all patients in the QUEST study had some reversibility. But again, this was not an important determinant of the response to dupilumab. Now, you could argue that reversibility and airway hyperresponsiveness are rather similar concepts. They're both expressions of airway lability. But again, it's difficult to argue that the benefits of dupilumab are mediated through an effect on this process. So I would argue all of the effects of dupilumab are due to inhibition of eosinophil trafficking to the airway epithelium, a process that occurs at the level of the blood vessel. So eosinophils are prevented from exiting the blood vessel. And that's why we see this strong relationship between efficacy and biomarkers of eosinophilic airway inflammation, and better efficacy in patients with nasal polyps, who are well known to be very eosinophilic patients. One of the big effects of the biologics we've talked about is that they allow patients to withdraw oral corticosteroids. And the table you see here summarizes the effect of the different biologics as oral steroid sparing agents. And I think it would be reasonable to say that the anti-IL-5s look as good as anything for this metric, whereas tezepelumab, which is targeting the magnet, the epithelium side, is less effective. So for the benefits of biologic treatment on oral steroid requirements, it looks very obvious to me that you have to hit the circulating eosinophil pretty hard, or you have to prevent eosinophils getting out of the vascular compartment. And if you don't do that very completely, as tezepelumab is the case with tezepelumab, you don't see oral steroid sparing effects. Now, there's been a very good unbiased indirect treatment comparison published last year in the Journal of Allergy Clinical Immunology, looking at the relative benefits of the different biologics, and it's summarized here in this table. And to cut a long story short, there is no clinically important difference in the benefits of the effect. You may get a little bit more on lung function with dupilumab versus the anti-IL-5, but you get more on symptoms with mepolizumab versus dupilumab. So 6 of one, half a dozen of the other. And I think it's difficult to argue with the conclusions of this paper that in individuals with eosinophilic asthma, mepolizumab, benralizumab, and dupilumab are similar in their effects on exacerbation, FEV1, and ACQ. Therefore, the benefits of biologics can be explained by their effects on eosinophil trafficking alone. In press is an update of this analysis, including tezepelumab, and the conclusions are very similar. If you look at the table on the top, there is little evidence that the effects of tezepelumab differ from dupilumab or indeed mepolizumab and benralizumab with this analysis. The plots that you see on the bottom are, I think, rather interesting plots. They're called surface under cumulative rate, SUCRA plots, and they look at the likelihood that the individual biologic will be ranked first, second, third, fourth, or fifth. And what you see is the individual biologics, benralizumab on the left, tezepelumab on the right, and you've got placebo on the far right. And you will see the area under the curve is related to the likelihood that that's the top biologic. And for ACQ, mepolizumab is the best performing biologic, whereas for lung function, dupilumab and tezepelumab seem to be the best. And for exacerbations, there's not a lot to choose between the three different groups of patients, and none of these differences are statistically significant. I'm going to finish by looking at an interesting UK study looking at what happens when you give prednisolone to patients who already have depleted eosinophils with mepolizumab. And the bottom line is nothing. So if you look at all the clinical measures here, asthma symptoms, quality of life, lung function, there is no statistically significant benefit of giving prednisolone. In other words, wiping out all aspects of type 2 inflammation does not produce any clinical benefits over and above what you've got by inhibiting eosinophils specifically, even though the prednisolone is clearly having a suppressive effect on type 2 inflammation as reflected by a reduced exhaled nitric oxide and reduced sputum eosinophils with prednisolone. So in conclusion, there is no beef in Dr. Wechsler's argument. I think that's my conclusion. Eosinophilic airway inflammation is the key inflammatory driver in severe asthma, as evidenced by the similar clinical effects of anti-IL-5 and the broader inhibitors, anti-IL-4 receptor alpha and anti-TSLP. And this indicates to me that other non-eosinophil associated type 2 mechanisms are not clinically important. This conclusion is reinforced by the lack of a clinical response to prednisolone in patients that are already treated with anti-IL-5 mepolizumab. So thank you very much for listening. Please be aware of the underhand, the possibilities that there will be underhand strategies at play. And remember, where's the beef? Thank you very much.
Thanks, Professor Pavord. Your personal attacks on Professor Wechsler are encouraged and approved. So this is going to be a hard one for Mike to beat, but let's see how he does, taking the con position for eosinophils being the key inflammatory driver in severe asthma. So Mike, I'll hand it over to you.
Thank you, Praveen. It's such a pleasure to be here today and to try to match wits with a truly master debater. Well, a few things. Let me just make sure that I can get my slides up. Hold on. Okay, great. So I just want to go over the history of this pro-con debate request. This really started on October 22nd, 2022. And I received notice from the society, we'd like you to be part of an IES pro-con debate. To which I said, sure, what's the topic? And they said, asthma. I said, sure, I like asthma. What about asthma? And they said, eosinophilic asthma. I said, sure, eosinophilic asthma. I like eosinophils. What's the debate? And they said, eosinophils are the key inflammatory driver in severe asthma. I said, sounds easy. I've published a lot on that, and I've been a card-carrying member of the International Eosinophil Society for over 20 years. Then they said, well, we want you to take the con side. I said, who is taking the pro side? And they said, Ian Pavord. And I said, this guy? I think I've heard of him. And they said, no, that's the younger, fun, smarter version of Ian Pavord. We want you to debate this guy. I said, oh, him, no problem. So with that, I will begin my quest to review the con of the argument. Here are some of my disclosures. My other major disclosure is that I am a member of the International Eosinophil Society for 20 years, and I've never disputed the fact that eosinophils are important. I also should disclose that the views I share today do not necessarily reflect the views of the International Eosinophil Society, but I do thank them for sponsoring this debate. My other major disclosure is that I consider myself a close friend and colleague of Ian, but I have witnessed him intoxicated on many occasions, as I believe he is this morning. Here we are a little over 10 years ago when he seemed a little bit younger, and you can see my glass filled with water, and he's got 2 empty glasses that had previously been filled with alcohol. More recently, this unnecessary vice of Ian's was demonstrated at a soccer match, and this is just November 2022. The two of us got together. Let's just say that he was as inebriated as usual as he is this morning. Let's get back to the debate. Are eosinophils the key driver in severe asthma? And that's really the key question. Are they the key driver in severe asthma? Well, let's review a little bit of asthma pathophysiology. This is from the New England Journal of Medicine from 1 year ago, actually almost a year to the day. Guy Brissell and colleagues wrote a wonderful editorial, a summary of what is severe asthma. And yes, in this morass of different cells, you can see that eosinophils are highlighted in approximately 10% of this slide. Another eosinophil found down low, and you can see the eosinophils are mentioned, and they obviously play an important role. But what about all of the other cells? Again, the question is are eosinophils the key cells? Well, what about T cells, B cells, dendritic cells, ILC2 cells, mast cells, neutrophils, macrophages, smooth muscle cells, and epithelial cells? How is it possible that eosinophils are the key driver amongst all of these cells regarding severe asthma? In fact, I was recently at a meeting with Ian, and he presented some data on type 2 inflammation and said type 2 inflammation drives a cycle of worsening lung function and exacerbations, leading to reduced quality of life. And there he is smiling, ha, 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 I'm a Brit, ha, ha, ha. And he was reviewing all of these data. But when you look at his slide more closely, can anyone actually spot the word eosinophil on Ian's slide? No, I see a lot of other cells. I see different cytokines. I see a variety of different cells. I don't see one cell being much larger than the other. Yes, there is an eosinophil in the top part of the figure occupying maybe 1% of this slide. But no, eosinophils do not, I guess, seem to be the key driver when he's not taking a pro side of a debate. And while the concept of eosinophilic asthma was novel maybe 10 years ago, isn't asthma more than just eosinophils? shouldn't we be looking towards the future and appreciate that asthma is really a heterogeneous disease? Well, let's hear what Ian has to say on the topic.
Very much about the question asthma do I have? Having a paradigm which acknowledges that asthma is very heterogeneous.
Okay, I don't know if you could all hear that, but the key line there was that asthma is a heterogeneous disease, and it's not just eosinophilic. In fact, in November, Ian agreed with this statement. He wrote, "I'm actually the first person to use the term non-eosinophilic asthma in The Lancet in 1999. I was like, really? You were talking about this in 1999? Well, I did in fact look it up. And sure enough, in 1999 in The Lancet, there was an article by Ian and colleagues about non-eosinophilic asthma. And I like to put the non-eosinophilic and Ian piece together. First of all, it shows how goddamn old he is that he was publishing this stuff back in 1999. But he reinforces the importance of non-eosinophilic asthma. Once again, Ian is showing his true colors. You know, if he's asked to do a pro side, yeah, he'll talk to the pro side. If he's asked for one company to talk about something, he'll talk about that as well. Well, now we see some of his true colors. So doesn't that mean we should be looking at other biomarkers beyond just eosinophils and beyond just targeting IL-5? Well, a second. Let's hear what Ian has to say on this topic. If I can find the cursor. Give me a moment.
We have exhaled nitric oxide, or FeNO, which reflects IL-13 activity in the airway. IL-13 induces nitric oxide production by the airway epithelium, so it's a beautiful biomarker of IL-13 activity.
Ian refers to another biomarker other than eosinophils as a beautiful biomarker. So it's not just EOs. On the other hand, I don't dispute the fact that blocking eosinophils helps asthma. Mepolizumab has been shown to reduce asthma exacerbations. There's a significant reduction in exacerbations. But if eosinophils are the key driver, why didn't it eliminate exacerbations completely in this study back from 2009? And furthermore, why was there no effect on lung function, methylcholine PC20, asthma symptom scores, or exhaled nitric oxide? Why is it that blocking eosinophil activity didn't benefit patients in terms of their quality of life or their lung function in this regard? This was seen as well in a more recent study by Hector Ortega and colleagues, where here again, mepolizumab reduced exacerbations, but it only reduced it by about 50%. What about the other 50% of patients? They don't benefit from eosinophil reduction. These were patients who were eosinophilic in nature. They're eosinophilic and they're not responding. What about the lung function? No significant difference with mepolizumab treatment. Now, when we look at benralizumab, another fine therapy, it's beneficial, it reduces exacerbations. In the study by Jean Bleeker and colleagues, it reduced exacerbations by 45 to 51%, again, in individuals with 300 eosinophils or more. But what about in the Fitzgerald study? There was only a 28 to 36% reduction in exacerbations. What about the rest of the time? Why is eliminating eosinophils with fine therapies like benralizumab not resulting in a greater reduction in exacerbations? And what about the fact that other agents that don't directly target eosinophils have comparable or superior effects? In fact, Ian himself in the last debate mentioned, well, there's no clinically important difference with anti-IL-5. In fact, some of these therapies reduce exacerbations to a greater extent, whether it's dupilumab or tezepelumab, and there's also benefits with omalizumab. Yes, mepolizumab, reslizumab, and benralizumab reduce exacerbations, but what about the other 50% of exacerbations? What about the greater efficacy demonstrated with quality of life? What about the greater efficacy in terms of FEV1 improvement with some of these other therapies? So what we're demonstrating is that, yes, anti-IL-5 blocking eosinophils is effective, but there are things beyond just blocking eosinophils. In fact, just a moment ago, maybe 10 minutes ago, Ian said there's no clinically important difference between biologics and no difference between anti-IL-5 therapies and the other biologics. He even used the quote, "There's little evidence." I was like, wow, shocking that a man of Ian's stature is quoting little evidence. When we look at some of the other studies, including anti-TSLP therapy with tezepelumab, which Ian denigrated a little bit, you can actually see that drugs like that are actually effective in patients who have less than 300 eosinophils, and even down to patients with less than 150 eosinophils, suggesting that there are mechanisms beyond just eosinophilia that are important in patients with severe asthma. You can see significant reductions in patients who don't have significant eosinophils at baseline. And therefore, it suggests that other mechanisms must be at play. Now, what about remission? It's a buzzword that people are talking about. Can blocking eosinophils induce asthma remission? This is one of the polling questions. It's interesting to see sort of the super responders. And this is from the Sirocco and Kalima studies. And the question that posed was whether or not benralizumab could help patients achieve clinical remission, meaning 0 exacerbations, an FEV1 improvement of greater than 100 milliliters, and an ACQ-6 less than 0.75. What proportion of patients were able to achieve that at 6 months, let alone 12 months? Less than 15%. And even if we loosen the criteria to say an ACQ-6 of less than 1.5, less than 27% of patients at 6 months and 24% of patients at 12 months were able to achieve that lesser degree of remission. What about airway hyperresponsiveness? This is a key component of asthma. Patients with airway hyperresponsiveness have cough, twitchiness of their airways. They react to a variety of different stimuli. Unfortunately, anti-IL-5s have failed to improve airway hyperresponsiveness in any of the clinical trials. So in summary, it seems as if eosinophils can play a role, but severe asthma, as Ian mentioned, is immunologically complex, and many cells are involved, from T cells and B cells to dendritic cells and ILC2 cells, to mast cells and neutrophils, to macrophages, smooth muscle cells, and epithelial cells. It also seems that blocking eosinophils helps asthma, but is not the be-all end-all. Blocking eosinophils doesn't eliminate exacerbations, fails to improve airway hyperresponsiveness. It fails to reduce other key biomarkers like exhaled nitric oxide that Ian, with his bomb and magnet story, failed to demonstrate a significant reduction in exhaled nitric oxide. It also has very modest effect on lung function and fails to induce remission in most. So I show you this last eosinophil slide just to say, thank you, eosinophils, for all you've done. But maybe your time has come and gone, just as Ian's has as well. Thank you so much.
Wow, that was something else, Mike. I am especially impressed by your real-time editing of slides in response to Ian's points. Very, very nimble. I just before I hand it over for a rebuttal from Ian, I just want to remind the audience that we'll have plenty of time for Q&A after the 2 rebuttals and further discussion. So remember to put your questions for the presenters into the Q&A box, and I'll be looking at those and be able to pose those questions to our 2 panelists, our 2 speakers when we get to the Q&A section. So please do post questions. And I think Ian is putting up his rebuttal slides, and I will hand it back over to him.
Thank you very much, Praveen. And as predicted, Mike went for the person, so no surprises there. What you heard was a very selective review of the literature. We can all find studies that support our hobby horse. What you saw from me was the most authoritative indirect treatment comparison. That's the best we've got when it comes to comparing biologic A with biologic B. No one's got a vested interest in one biologic being better than the other. So the data I showed, I think, quite convincingly demonstrated that they really look very similar. And the reason they look very similar, I think it can be explained by this magnet and bomb concept that Mike very kindly introduced, which sees exhaled nitric oxide and blood eosinophils, which are the two most informative biomarkers we have, indicate different aspects of eosinophilic airway inflammation, with exhaled nitric oxide telling you about the strength of the chemotactic pull of eosinophils towards the epithelium, the magnet, if you like, and blood eosinophils telling you about the number of these toxic cells, which you could liken to bombs that are available to be pulled towards the epithelium. And if you have a scenario where you have both a magnet and a bomb, you are in trouble. But if you can get rid of just one of these, and with mepolizumab and benralizumab, you disarm the bomb, and with tezepelumab and dupilumab, you have a bigger effect on the magnet, then you achieve very good things and very equivalent things. There's no difference in what you achieve because you have blocked this process by taking out one of the arms of it. Now, this paradigm Simon Couillard really developed, and Liam Heaney and others, allows us to begin to think about whether we might be able to better match patients to biologics. And I think this is where Mike and I might agree. And that would be a nice end to a debate. So, for example, are we able to identify bong and magnet patients? The table on the left is some imaginary characteristics of the two different groups of patients. But on the right, you can see some real data from the DREAM and QUEST study looking at the response to dupilumab in red and mepolizumab in blue in different patient groups. And I'm going to highlight the red group, the red circle, which is what you might call magnet predominant patients. They have a high pheno but normal blood EOs. These patients respond to dupilumab but not mepolizumab. In contrast, if you look at the bottom right, the blue circle, these are patients that have blood eosinophils but no pheno. They respond to both mepolizumab and dupilumab equivalently. So some evidence to support this stratification step. But it's clear that what both of these treatments are doing is preventing eosinophils getting to the airway epithelium where they cause issues. But they're doing it in different ways. We're disarming the bomb with anti-IL-5, and we're turning off the magnet with dupilumab and tezepelumab. The effect of doing that is very similar. The key thing is to inhibit eosinophil migration to the epithelium, and I stand by my earlier comments. Mike, over to you.
Thank you, Ian. Yeah, share my screen again. Okay. Well, once again, I want to thank Ian for a really compelling debate. Again, you saw in his rebuttal, he talked about imaginary characteristics, once again, showing that his sense of reality is not all there. I call upon my friend, Dan Aykroyd, a fellow Canadian. Ian. So I want to thank Ian for that. I want to point out a few other things. The eosinophils might be playing a role in asthma. but we've seen recently that depleting tissue eosinophils doesn't improve outcomes in chronic rhinosinusitis with nasal polyps, and even in eosinophilic esophagitis. We recently saw data showing that eosinophils, when they're depleted, they have no clinical effects in those specific entities. Another important question is really about the relationship between distorted airway function and type 2 inflammation.
No, it's that there is not a very close relationship between disordered airway function and type 2 airway inflammation on the other. They are to some extent, independent treatable traits that drive different clinical problems. So disordered airway function drives symptoms, obviously very important, and we know we can modify that with bronchiolitis particularly. Type 2 airway inflammation seems to simply be associated with asthma attacks. We know we can modify that with different treatments.
So Ian again is suggesting, he says, yeah, well, there's disordered airway function. I mean, why would anybody think that's important in asthma? But it's totally dissociated from type 2 inflammation. I mean, this is like Ian debating himself. This whole argument, it's fascinating. Even this wonderful figure that Simon Couillard and Ian developed, when you look at the top lines, you see that it's really patients who've got the higher nitric oxide who have higher exacerbation rates, asthma attack rates, than patients who have higher eosinophils. It seems to be that exhaled nitric oxide is the key driver here. Looking, for instance, at the eosinophil groups greater than 300, it isn't the eosinophils, it's actually the nitric oxide. When the nitric oxide is high, that's when patients have an asthma attack. So I leave you with the final question. Are eosinophils the key driver in severe asthma? That's what we're here to debate today. And I went to the literature to find a few quotes from Ian. One was from the Lancet Commission, Redefining Airway Diseases. Ian wrote, asthma and other airway diseases consist of a heterogeneous mix of pathologically distinct processes. Another quote, this again is from the literature, you can look it up. The absence of eosinophilic airway inflammation is also important. Another one, the identification of variable airflow obstruction in the definition and diagnostic process for asthma may be one reason why it's widely assumed that this pattern of airway dysfunction identifies discrete airway pathology, eosinophilic airway inflammation. This is now known to be incorrect. I mean, do we have to go any further? But then even a little coup de grace at the end, 40 to 50% of patients with objective evidence of variable airflow obstruction have non-eosinophilic pathology or no detectable airway inflammation. I think the answer is there, but I'll leave Ian with the final word. Here he is proudly standing in front of a nice videograph. And this is something that I will agree with, Ian. We do have a responsibility to advocate for our patients and to educate clinicians about this new way of thinking about airways disease and stratifying airways disease. I, for one, am grateful that we have all sorts of different therapies that target eosinophils and that target other parts of the inflammatory response in asthma. Yes, eosinophils are important. I've never denied that. I'm still a member of the International Eosinophil Society until perhaps they kick me out after this debate. But I'm also happy that we have other therapies that target other parts of the inflammatory pathway, whether it's IgE and the mast cell, whether it's IL-4 and IL-13, which you said is a fabulous target as well, or TSLP and other cytokines that we're looking for in the future. But I thank you, Ian, for your excellent debate strategies. It's really great to have you on my side as I'm able to quote you. You're easy to find on the internet, and it's such a pleasure to debate with you. So thank you so much.
Wow, that was fantastic from both of you. If I knew it was going to be this entertaining, I would have popped some popcorn this morning for watching your presentations. And Mike, you are correct. We're having a meeting after this to figure out whether we're going to kick you out of the IES. I'll circle back and let you know. We'll now do some post-debate questions and get into the Q&A. There's already some questions in the Q&A, but let's do a little bit of the post-debate questions to get people's questions kind of primed. Andrea, can you do the first post-debate question, which is a repeat of the first question? Are eosinophils the key inflammatory driver in severe asthma? So let's see if there's any changes.
Well, Ian waffles a lot, so we know which way he's going to go.
You don't tell me, Mike, that you voted no for that.
Oh, come on, Ian.
Let's
Don't
see
tell
what
me you didn't vote no for that.
So, okay, and I'm actually not sure whether everybody who's listening in can see the results. I'm assuming yes, but we had about a 75-25 split when we for the initial pre-debate poll. So we now have almost a 50-50 split, yes, no, slightly toward.
And I want to point out that this is the International Eosinophil Society. Of course they're going to vote yes.
That's a win. A win's a win, Mike.
Yeah, okay. I think I turned a few more heads than you did.
So let's go to the second polling question. A couple of these are questions that I put in here. I'm just curious about what people think. Blood eosinophils are an adequate biomarker for predicting response to eosinophil depleting therapies, yes or no? Okay, go ahead. Should be enough time. So in case people can't see it, 79% of people said yes, blood eosinophils are an adequate biomarker for predicting response to eosinophil depleting therapies. All right, do the next polling question. Sputum eosinophils are an adequate biomarker for predicting response to eosinophil depleting therapies, yes or no? And we didn't go into this too much during the presentations, but
because no one can measure them.
Let's see what people think. About the same split, 74-26. So about 3/4 yes, 1/4 no. And then I believe there's one more post debate question. Yeah. FeNO is a good predictive marker for response to eosinophil depleting therapies, yes or no? And let's see what people think. So that's flipped the other way. FeNO is 26% yes and 74% no, that it's a good predictive biomarker for eosinophil depleting therapies. And before I get into Q&A, any kind of reflections or comments from Ian or Mike about the post-debate questions?
No, I mean, I'm interested in the sputum eosinophils, and Mike says this is not a practical way to assess airway inflammation. Is absolutely right, but it also was very disappointing in the DREAM phase 2b study as a predictive biomarker. And it's pretty clear that the anti-IL-5 biologics are hitting circulating eosinophils. They're the best predictive biomarker, and that seems to be the target. And in so doing, they will deplete sputum eosinophils unless you have a very strong sort of chemotactic force pulling them in. But nevertheless, their primary site of action is circulating eosinophils, in my view. Yeah.
Mike, anything additional from you about the post-debate questions?
No, I think that one person turned more heads than the other. And this is a tough audience of eosinophilologists. It would be like walking into a bar and saying, well, who doesn't want to drink? I think it was a tough road tough thing to battle against here, but I think I did a pretty admirable job.
Yeah.
I think it turned a few heads.
I think you conflated a few things, though, Mike, and that's it's clever. It's very clever. You are a master debater, as you say, but but you conflated a few things. Asthma is a heterogeneous condition, yes, but the benefits of the question was, what's the key inflammatory process? The key that allows you to have more than one inflammatory process.
Yeah. Well, there. I think what you showed with your confusogram and what I showed in mine is similar. There is no one key, and that's the major point. Asthma is a heterogeneous disease made up of different cells, different cytokines, different pathways, and saying that one pathway is the dominant one, I think, is a mistake. I think there's many, many pathways. There's many, many ways to get to asthma. The issue is that there are many, asthma is so heterogeneous in terms of its symptoms. Some patients have chest tightness, some patients have cough, some patients have wheeze, some patients have airway hyperresponsiveness, some patients have variable airflow obstruction. And they can't all be related to the eosinophils. And we've shown that. We've shown that blocking other pathways other than blocking eosinophils has that benefit. And we've also shown that many of these therapies that we have that are very effective really don't have much of an effect on eosinophils at all. You show data about anti-IL-4 and 13, where we know that there's no significant reduction in eosinophils. And even in tissue eosinophils, there's been nothing to demonstrate that airway eosinophils have been reduced in patients treated with anti-IL-4/13.
Great. So let's get to some of these questions. They have piled up. Thanks everybody for posting some questions. And both of you can kind of freestyle answer these. I'm going to pair two questions together that are regarding the Yang study that was presented by Ian. The first question regarding the Yang study was, would one conclude that if a patient is receiving mepolizumab, you should not give oral corticosteroids if they exacerbate? So that is the first question regarding the Yang study. And then the second one is, given that Ian Pavord highlighted in his talk the study by Yang et al. That there's no response to prednisolone in patients taking mepolizumab, why then do we treat the 50% of patients who have had an exacerbation while on mepolizumab with prednisolone? So kind of similar paired questions.
Shall I go first, Mike?
Yeah, go ahead.
Yeah, so I think they're both great questions. I suppose one way to think about answering them is to ask another question, which is, why does prednisolone work in asthma when inhaled steroids don't work? And I think the only thing that prednisolone does that inhaled steroids don't do is to deplete circulating eosinophils. And when you have a situation where the airway epithelium is, the chemotactic forces pulling eosinophils in have become completely unresponsive to topical steroids, your only opportunity to reduce that process is to tackle the circulating eosinophil. So you accept that the magnet is on, but you deplete diffuse the bomb, if you like. And so if that's the correct paradigm, why then are we doing it twice? In a patient that's on anti-IL-5, you've already depleted the eosinophils. Why do you then choose to do it again with prednisolone with potential side effects? And I think that's a really good question, because we need clinical trials showing that there is no effect of prednisolone in people that are treated with an anti-IL-5. And then the difficult question becomes, well, what is the definition of no effect? What's the minimum benefit that you would give a course of prednisolone for? And that becomes quite a difficult study, because I think we don't have a consensus on that. But I tend to say to patients that are on anti-IL-5 that they should have a higher threshold for using prednisolone and that it's quite possible that what prednisolone does is already being done by the biologic that they're on. So that's my response, but we really do need a good trial, I think, and it's a difficult one.
I don't think these are difficult questions at all. I think the reasons we give corticosteroids when you've depleted eosinophils with eosinophil depleting therapies is that there are mechanisms beyond eosinophils that tend to be responsive to corticosteroids. Whether
no, I don't doubt that, Mike, but the point I made is that they're already taking 2 milligrams of fluticasone propionate straight into the organ of interest. You know, it's going straight in. So that should have happened with the inhaled treatment. So unless there's an access issue, which is possible, I suppose.
Yeah, I mean, I think it's challenging, but I think sometimes there might be variability, pharmacogenetic variability. There might be some anatomic variability that allows full penetration of inhaled corticosteroids into the airways, peripherally, for instance. But it's clear that there are mechanisms beyond just eosinophils, and perhaps some of these are steroid responsive. I challenge you, Ian, to not give corticosteroids to your patients who are exacerbating when they've got 0 eosinophils, as we see in many of our cases.
Yeah.
What's the mechanism of their asthma?
Well, we've got the Yang study showing that, in fact, there is relatively little impact of, it was a reasonably powered study that's for, outcomes that matter to patients. There was really little evidence that prednisolone did anything. So, that's the evidence. And of course, there is a downside to giving prednisolone. No, I don't think I disagree. I think, we need trials, and they're going to be difficult trials to do because, we have to establish, in essence, demonstrating that the drug doesn't work is really difficult. It's easier to demonstrate that it works. Yeah.
Great, let's move on to some additional questions. I'm just going mostly in order on these. The next one is recently published data suggests that eosinophilic depletion has effect on airways hyperresponsiveness. A paper is cited that you may be familiar with that's titled "Eosinophil Depletion with Benralizumab is Associated with Attenuated Mannitol Airway Hyperresponsiveness in Severe Uncontrolled Eosinophilic Asthma." Any comment from Dr. Wechsler on this?
I believe that it's possible that eosinophil depletion can have some benefits in terms of airway hyperresponsiveness, but these benefits have not been consistently shown. There have been multiple studies now that have shown there is little effect in terms of airway hyperresponsiveness with MEPO and with Benra. So yes, I do think that if you look and do enough studies, you will find the result that you want. But I think what we're looking for is consistency. And can you reliably tell your patient that you're going to eliminate airway hyperresponsiveness? And I don't think that's the case.
I think the study that the question is referring to is from Lipworth's group, and it was an uncontrolled study. So, we really do need placebo-controlled studies. So I kind of agree with Mike. We do with tezepelumab have placebo-controlled data showing an effect on mannitol airway responsiveness, which is modest. It's under 1 doubling dose, but nevertheless, it's there. The only placebo-controlled study I can think of with anti-IL-5 looking at airway responsiveness was the original Lecky paper, many years ago, which was negative, and that was histamine airway responsiveness. So I think an uncontrolled study is problematic because you're going to see regression to the mean and placebo effects, etc.
Agree.
Great. The next question is regarding eosinophilic airway attacks. Are there any experiments or results on relieving the effect of anti-PGD2 in eosinophilic airway asthma?
Yeah, there's actually, these drugs have gone into phase 3, and we've got very big studies. The proof of concept study from Chris Breitling group showed that fevipiprant reduces eosinophilic airway inflammation in severe asthma. But in the phase 3, the Leicester studies, which were not perfect, and they were particularly affected by a big placebo effect, and that's always a problem in studies of type 2 targeted treatment, because the placebo effect tends to be seen most obviously in people with high biomarkers. But the Leicester studies I'm interested what Mike made of them. There was probably something happening, but it just wasn't enough.
Well, these were large studies,
Yeah,
and the effect of blocking CRTH2 or prostaglandin D2 was not shown to be beneficial. And usually when there's a large placebo effect, it's not just because of the large placebo effect, but it's also due to the lack of the clinical benefits with the specific therapy. Now, could it be because the dosing wasn't high enough? Could it be because you need to target beyond just prostaglandin D2? I mean, there are many specific studies that have looked at a variety of different entities, whether it's dexpramipexole, which depletes eosinophils, whether it's Siglec-8 inhibitors, which have looked beyond just asthma, but in other entities which haven't necessarily been effective. I think there's a lot that goes into doing clinical trials, choosing the right outcomes, choosing the right patients, choosing the right dosing. Those are all key components. And I can't say for certain that blocking prostaglandin D2 won't be effective if done in the right way, in the right study, in the right patients, with the right dosing. But you have to do that whole combination of factors. But it was clear, based on the phase 3 studies, that there wasn't a significant benefit in those patients.
Great, thanks. So the next question, in support of Professor Pavord's argument that could the phase 3 trial on the combination of anti-IL-33 and dupilumab, which both of you are authors, which did not detect any additive synergistic effect of the combination, both individual biologics having similar impact on asthma readouts. Yeah, that's supporting Ian's argument, is what the questioner is saying. IL-33 is a key inducer of IL-5 in eosinophilia. Accordingly, anti-IL-33 shows effects on eosinophilia very similar to mepolizumab. It would, if this is correct, not come as a surprise that dupilumab and mepolizumab, if combined, would also not show much synergy in severe eosinophilic asthma. So that's the crux of the question. What do you think about the potential for synergy between?
I actually think that this goes against Ian's argument in a way. You're seeing efficacy with dupilumab with blocking IL-4 and 13. When you block IL-4 and 13, the benefits you're having are you are blocking IL-4 mediated production by B cells of Ig that act on mast cells. So you're blocking that component. You're blocking IL-13 mediated effects in terms of airway hyperresponsiveness, in terms of nitric oxide production, and in terms of mucus production. And to some extent, you're blocking eosinophil trafficking as well. When you block IL-33, you're working upstream, and IL-33 has an impact in terms of ILC2 production of both IL-5 and IL-13. You're already blocking IL-13 with dupilumab in this study. And so what you're doing beyond that is you're blocking IL-5. And we showed that there was no significant additive effect of blocking IL-5 beyond what we did with blocking IL-4 and 13. So I think this goes.
I don't know, Mike, if I agree. I mean, that was an interesting finding and somewhat unexpected finding.
I agree.
But there wasn't an additive effect. In fact, if anything, it seemed to be a subtractive effect. That's slightly over-interpreting the data. But that would fit with the magnet and bomb concept, because if you switch the magnet on, there is no point in depleting eosinophils because there's nothing pulling them towards the eosinophils. So the point I tried to make was that you have to have both of these process is active to be in trouble. And what biologics do is they disarm one of them. Now, the question, I think, is, would there be benefit in disarming both of them? And my model would suggest there wouldn't be. But, you know, that remains to be seen. And all we've got, looking at dual biologics, you know, Dupi and MePO, for example, all we've got are case reports. And they are encouraging case reports, but I'm not sure they're strong enough evidence to draw any conclusion, really.
Yeah, but by blocking upstream with, say, by blocking TSLP, you are having the benefits of blocking IL-4, 5, and 13. And we've seen some, you know, excellent results by doing that. You're effectively, you know, giving an anti-IL-4 and anti-IL-4, 13 and an anti-IL-5 at the same time.
Yeah, but you're not inhibiting either of those axes as completely as the more selective blockers. So you particularly your effect on circulating EOs is substantially less than you get with the anti-IL-5s, particularly Benra, you know, which wipes them out.
Depleting, you're absolutely depleting them, yeah.
Yeah. So you get a halving of the eosinophils with Tezi versus an 80% reduction with MePO versus a 98% reduction with Benra. So they're working, you know, not as well. They have a broader effect, but it's not as complete.
Yeah, I mean, Ian's thoughts are very interesting. I mean, he, you know, is opposed to disarming bombs. I'm actually pro world peace, but you know, those are just some of the differences between how the two of us think.
Yeah.
Let's move on to the next question. The MEX study with MEPO reports two types of asthma exacerbations in patients with severe asthma on treatment with anti-IL-5. How could we identify these patients?
Yeah, that's so the MEX study, for people that don't know, was a study we did in the UK where we looked in detail at people who were having exacerbations whilst on mepolizumab. And we found that they were very heterogeneous, and that there was a roughly 50-50 split. So 50% were non-eosinophilic, characterized by a raised induced sputum neutrophil count, a low exhaled nitric oxide, and a very high likelihood that you would find a pathogen, either a virus or a bacteria. The other group had a high sputum eosinophil count, they had a high FeNO, and there was a low likelihood that you would find a pathogen. So the suggestion would be that at least half of the exacerbations that occur on MePO are due to incomplete blockade of type 2 airway inflammation, I think, potentially, and half are due to a primary infection. Yeah. So going back to the earlier discussion we had about should we not give prednisolone in exacerbations occurring on mepolizumab, you need to be aware that some exacerbations occurring on mepolizumab are still type 2 high and potentially might still respond to steroids. So that's what we showed in MEX. And FeNO proved to be an extremely good way of discriminating the infection-driven events from the persistent eosinophilic events. And if your FeNO is below 25, you will not see eosinophils in the sputum, and your patient's very likely to have an infection, whereas if it's above 50, pretty much guaranteed you had an eosinophilic event. So FeNO is really helpful in MEX.
Great. Any other comments, Mike?
No, I agree. I think one of the things that I think that was an important study. I think that it highlighted the impact of potential airway infection of inducing exacerbations. And I think that's a really important concept. I think we have to think about the heterogeneity of asthma exacerbations as well. And it isn't all just inflammatory. You can induce some of the inflammation by infections, and some of it's going to be non-type 2 mediated infections. And I think that we need to think about, we need to characterize, we don't do a good enough job in general clinically characterizing exacerbations. And, in some cases, maybe we should be giving more antibiotics. And what's the role of giving chronic suppression with macrolides, for instance, has been shown, multiple studies, both in adults and in children, showing that there's efficacy there. So I think it highlights, again, the heterogeneity of asthma, the heterogeneity of the exacerbations, and then we need to take a multi-pronged approach. We need to do a better job of characterizing our patients.
Right. The next question is about mucus plugging. So it's query, mucus plugging and severe asthma related with bomb and or magnet, question mark.
Both. You have to have both. You have to have a bomb and you have to have something that's pulling it towards the epithelium. That's why pheno and blood eos have additive, predictive, and prognostic value. Yeah. And if you take one of them away, you stop forming mucus plugs. So that would be my answer. And the original Dunnican study, which is where they attempted to quantify mucus plugs, did show a nice correlation between the mucus plug score on CT and the induced sputum eosinophil count. Well, saying nice, there was a correlation. It wasn't that close, but nevertheless, there was a correlation.
Right. There's also an additional magnet and bomb question. Just I'll ask along these lines. That's more general. Going back to the magnet and bomb concept, is there an advantage of disarming one versus the other?
That's a really great question. I think there might be. So when you look at the Oracle score, the blood eosinophils are more influential than pheno in predicting exacerbations. But we presented some data at the ATS this year looking at decline in lung function, which is a problem for some of our patients with severe asthma. And we found that pheno was much more predictive of that than blood eos. So, that's observational data. It's not, we haven't nailed it, but yeah, then the answer to that question is great question, and there might be.
Yeah, I think it's important to target multiple pathways, and blocking eosinophils and pheno or IL-13 mediated pathways, I think, are both important. And I wouldn't necessarily, it's hard to say that blocking one over the other. And the data that we've showed today show that no matter what we do, we're still not perfect. And I think that we still need to learn a lot more about the mechanisms. I think we need better biomarkers beyond just eosinophils, beyond just pheno. I mean, I'm happy that we have at least those two biomarkers, but wouldn't it be great if we could more precisely treat our patients and target our patients a bit better with other more novel biomarkers? And I think that's where we're lacking. Ideally, it would be nice to use more genomics and genomic biomarkers to identify what are the mechanisms responsible for inflammation in one patient versus another, and over time, because it's dynamic. And one of the things that I think we haven't discussed enough is how dynamic these things are. And yes, the eosinophils might be playing a role in some patients some of the time. Nitric oxide might be playing a role some of the patients some of the time, IL-13 mediated effects, and infections might be playing a role some of the time. And I think we need to think about asthma as not just a heterogeneous disease, but also as a dynamic disease over time.
Yeah, Mike, I think you just answered a question that was in the chat about, are there any other biomarkers for giving biologics beside eosinophils and exhaled nitric oxide, which, I think, is a future frontier that you said we need to work on. And we'll finish with one last question before I hand it back up off to Florence for some concluding comments. But this is a good question. Dr. Pavord, are you arguing that eosinophils are a major inflammatory driver in severe asthma overall, or in severe eosinophilic asthma?
Yeah, I don't think that I I don't want to give the impression that I don't believe severe asthma to be heterogeneous. Clearly it is. The debate was about what is a dominant, can we identify a dominant process that's more important than others? And I believe we can. The Quest study, which was an unselected population, probably 80% of the people in Quest had some evidence of type 2 inflammation, and about 40% had very compelling evidence of type 2 inflammation and did extremely well with dupilumab. And in RASP UK, when we specifically targeted people with low biomarkers and we withdrew treatment, most patients developed markers of type 2 inflammation. So yeah, I think it's important because it's treatable. It's a process that's treatable, so we need to know about it. But there are many other processes. Mike is absolutely right. There are other processes, but I took the debate to be, it's a key. It's one of the more important ones, and I think it is. It's up there as it's the most important inflammatory process. And part of that is because we can measure it easily and we can treat it effectively. That makes it very important. Clinical practice is about trying to find what we can do that can help the patient. And this is one of the real pros, one of the treatable traits you absolutely have to look for.
Great. And Mike, we have one final polling question before, but I'll let you have the last word before we go to that one final polling question.
Yeah, I think Ian said it all himself. We're, I think, exciting times, but challenging times. And I've never disputed the fact that eosinophils play an important role, but I do think that there are many cells that play important roles. And I think that our understanding of severe asthma, while it's advanced a lot in the last 15 years, and I have to say a lot of the advancement is because of work by Ian and his group over the last couple of decades. I still think that there were still a ways to go, but I'm excited because we do have a lot of therapies. And I want to thank Ian and the International Eosinophil Society for sponsoring this. Thought this was an excellent debate, and I hope I'm allowed back into the International Eosinophil Society's inner sanctum.
Thank you, Mike. Yeah, I'm afraid I've got bad news for you because I'm just looking at the chat here, and they've already given you the sack, and I've got free membership. So you're going to need to find a new society. You've burnt your bridges, I'm afraid. Thank you, Mike. No, I mean, I love listening to you, Mike. You're one of the great thinkers in airways disease, and you've always got an interesting, different take on it, and of course, been a huge driver of the progress that we've made. It's been exciting working with you.
Thank you, Ian. And next time, I'll bring you the Diet Coke.
Well, thank you both. And it goes without saying that these questions that we pose for these kind of debates are straw men to tease apart the issues, the complexity that are contained within. The questions are obviously simple and maybe not reflective of the complexity, but both of you really did a great job of teasing out the complexity that's inherent in a question like that. And we're going to post the one last polling question here. I think Andrea's got that. Who is the better humorist? And we can, and you have the choice between our two debaters. I'm going to pick, but not tell anybody who I picked. All right, let's see what people had to say. This might be the truly who won.
Hello.
Oh,
Thank
wow.
you. Thank you.
Okay.
Let me get a screenshot of that. Don't put it down just yet.
It's gone.
Okay, there we go.
It's recorded. Don't worry.
And by the way, I know most people answered who is the better person also, but I appreciate that as well. Thank you.
So Florence, I'm going to hand it back over to you for concluding remarks.
Thank you. Thank you very much, Praveen. So Andrea, can you put the slides up? So first of all, I would really like to thank Praveen for really navigating this very animated debate and question and answer session. We had really, really nice questions. We had a nice discussion after the presentations. So I think that this webinar was really very successful and interesting. I'd also obviously like to thank our speakers who have not disappointed us in the least today. We were both entertained and educated, so thanks to both of you, Ian and Mike. I think it's best I refrain from commenting on the outcome of the debate, especially regarding Mike Wechsler's imminent expulsion from our executive board. That being said, I'm sure that today's presentations have brought all attendees up to speed on the key concepts and studies that are needed to begin to even start addressing today's questions. So really, I would like to thank everyone very warmly for their interventions. Next slide. I'd like to thank today's sponsor, which was actually Amgen. While thanking them, I would also like to thank all the sponsors that support our society throughout the year by supporting our advisory council. Next slide. This is the announcement for those of you who may not be aware that we have now a full scientific program for our 12th symposium, which will be held at McMaster University in Hamilton, Canada. You can visit our website if you want details on the program. It's a very, very exciting and interesting program. The meeting will be held in July this summer in Canada. Next slide. These are our links for following us on social media. Next slide. And if you want to learn anything else about the programs, if you're interested in our society, you can either visit our website by following the link at the bottom of the slide or write an email to the email address which is shown here. So thank you everyone for attending the meeting today. Thank you to the moderator, to the speakers, to the attendees, and I look forward to seeing you soon. The next webinar will probably be a trainee dedicated webinar. So trainees, please visit our website to keep posted on that webinar, which will probably be held in March this year. Have a nice day, everyone. Bye.